So I'm going to talk about the new ACC/AHA guidelines, what's new and what you should know. So hopefully in the 11 minutes that I have, I'm going to try to encapsulate that. Why is this important? Because this is the first unified acute coronary syndrome guideline since 2014. So we waited a long time for this information. And there are major changes in the antiplatelet therapy. There's definitely more emphasis on bleeding risk, which is very important, and the alignment with contemporary PCI practice, which is even more important. Now we actually have guidelines that coincide with what we do on a daily basis. And then it adds in about the personalized decision making that we need to participate in. So what's new? Well, now we have a unified guideline for STEMI, non-STEMI, and unstable angina. And they actually, in the document, have definitions of all of that. There is much more emphasis on type 1 MI in this document. Really excludes type 2 MI. There's no formal recommendations with regards to type 2. And there's new procedural evidence incorporated which addresses antiplatelet therapy, anticoagulants, timing, and imaging. I don't have time to go into all of it. I'm really going to try to address the issues of antiplatelet therapy and anticoagulants. So there is some recommendations with terms of procedural and invasive strategy updates. One of the strong recommendations is radial access is strongly preferred. Why? Because of the bleeding risk. It really makes an emphasis on the imaging in terms of IVUS, and OCT now is class 1 indication. And then, of course, the idea of complete revascularization. In the past, we would do the culprit vessel, but now, given the body of data, complete revascularization is emphasized in this. Let me see, did I go? Yeah. In terms of anticoagulation, we still say unfractionated heparin in terms of STEMI and in non-STEMI, and bivalirudin is class 1 in STEMI because of the reduced mortality and bleeding that's been associated with that. But it does say do not use fondaparinux alone during PCI because of the risk of catheter thrombosis. So that's a slight bit of a change. In terms of antithrombotic and pharmacologic updates, it still defaults the 12-month dual antiplatelet therapy. That continues to be a recommendation, but now we have options for high-risk bleeding patients because there is a clear preference for ticagrelor or prasugrel, as Dr. Hadley-Wilson had mentioned in the earlier session. And so what about aspirin? Well, aspirin is still recommended in terms of oral loading dose of aspirin in terms of all of the patients with acute coronary syndrome. But in terms of the P2Y12 inhibitors, we should certainly add that. But in a patient with a history of a stroke or TIA, it again says class 3 for prasugrel, so we want to avoid prasugrel in those patients. Again, preferred ticagrelor and prasugrel, no preference between the two except for the patients that have had a stroke. We don't want to use a prasugrel. And then clopidogrel is only to be used if it's contraindicated, if the patient is intolerant, or if it's not accessible. So again, clopidogrel is there, but we don't want to reach for it like we want to reach for ticagrelor or prasugrel. So when do you start it? Well, you start it early. If you have a delay in terms of taking them to the cath lab greater than 24 hours, you can go ahead and give it. If you have an early angiogram planned at less than 24 hours, you want to defer till you know what the anatomy of the patient is. And then cangrelor is reasonable if there's no prior P2Y12 and you're going straight to the cath lab. So these are the recommendations about when to start the P2Y12 inhibitors. What about how long? How long should you do dual antiplatelet therapy? And this is where the newness comes in from the guidelines. Ticagrelor monotherapy. So still class 1 is going to be the 12-month dual antiplatelet therapy, but we now have this abbreviated strategy of ticagrelor monotherapy after 1 month in those patients that we identify as being high-risk bleeding risk. And so what they recommend is ticagrelor monotherapy after 1 month or greater of dual antiplatelet therapy. And this is a real paradigm shift from the 12-month of dual antiplatelet therapy. Now, they don't recommend that if you have clopidogrel that you do shorten clopidogrel monotherapy, nor is the recommendation shorten prasugrel monotherapy. So if you're going to do monotherapy and you're going to shorten it, you want to think about ticagrelor, and I'll get into that in just about a second. So what is the rationale for the monotherapy? Well, there have been multiple randomized trials across diverse designs and patient populations that evaluated ticagrelor monotherapy after a short course of dual antiplatelet therapy. And really, all of these studies show that if you stop aspirin and continue ticagrelor alone, that you did not have any adverse events in terms of ischemic issues, and so consistently has shown safety, particularly in patients with high bleeding risk patients. And I have some of the studies listed there: Global Leaders, Twilight, Tycho, TPAS Ultimate, and Sydney 4. And so in the Twilight study, there was a 44% bleeding reduction, and it was non-inferior ischemic outcomes. The Global Leaders, you showed a bleeding reduction in the patients with acute coronary syndrome subgroup, and of course, consistent safety and bleeding in some of the other trials. When it comes to Sydney 4, which looked at the totality of evidence, it was a meta-analysis of 24,000 patients, and it showed that ticagrelor monotherapy was non-inferior to dual antiplatelet therapy for MACE. And there was a 66% reduction in terms of major bleeding. So it conclusively showed that there was no ischemic access, meaningful bleeding reduction, and a possible mortality benefit consistent with prior meta-analysis. And I think this brought together all of the data that shows this shift in terms of our recommendation for these high bleeding risks, where you can think about 1 month of ticagrelor as monotherapy. What is the additional rationale for shortened dual antiplatelet therapy? Well, we all know that we've made lots of advances in terms of stent design and PCI techniques. And so I think that also has been part of the equation. I think we all have become recognizing the high bleeding risk. And then I think we have, more potent P2Y12 inhibition without aspirin therapy, whereas in the past we only had clopidogrel. So who should get the 1 month abbreviated strategies? Well, I think older patients that are potentially at higher risk for bleeding. I think the high bleeding risk in terms of ARC and the precise DAP scores, and then those patients with chronic anticoagulation. A lot of our older patients that have atrial fibrillation that are already on one of our other agents that we need to think about in that. Look at the frailty of the patient. Do they have chronic kidney disease? Do they have an underlying malignancy? What are their comorbidities? And have they had a history of recurrent bleeding on dual antiplatelet therapy? I think those are our patients. So I think about chronic anticoagulation, what the recommendation, and I think all of you in the audience know this very well, triple therapy for 1 to 4 weeks. And even that's shorter. It used to be 4 weeks, and now they're saying 1 to 4 weeks. And then you can just do the oral anticoagulant plus clopidogrel. Now you want to think about those patients and think about clopidogrel. And you want to avoid ticagrelor or prasugrel with the oral anticoagulant because of the bleeding risk. Again, a huge emphasis in these guidelines for bleeding risk. So the use of clopidogrel, should we even use it now given these guidelines? Yes, it's appropriate for these high bleeding risk patients, those patients with chronic oral anticoagulant. If there's a cost issue or an access issue, certainly clopidogrel is still recommended. If you have somebody that's older or has a weight of less than 60 kilos and then post-fibrinolysis, these are the ones that you want to consider potentially using clopidogrel. And so I think the guidelines do a very nice the risk of who should you use what in terms of dual antiplatelet therapy. I don't have time to go into this in detail, but know that these guidelines are rich with these tables that you can use for referring to figure out what you should use for your patient. It's actually very, very well done. And so I want to end in the last few minutes with some practical pharmacologic pearls. Prasugrel, avoid this in patients with prior stroke, TIA, and certainly reduce the dose if the patients are elderly or less than 60 kilos. When you have ticagrelor, almost be prepared that the patient may complain of dyspnea, but that usually resolves within the first 24, 48 hours. So be prepared when they tell you that. Bradyarrhythmias is something to think about. If you're using cangrelor, ensure that you have correct transition to oral agents. And then aspirin, chewable is preferred, non-coated, but certainly the evidence is limited when it comes to this. I wanted to talk about what is doing a comparison in terms of guideline. The ACC/AHA makes it class 1 ticagrelor monotherapy greater than 1 month. ESC still calls it a class 2A single antiplatelet after 3 to 6 months. So this is a true paradigm shift. And I think that the US is certainly more proactive based on the trial strength, and I showed you some of the data for that. So this is the reason for this big thing. So how do I apply the guidelines in my practice? I wanted to end it with this. So I use ticagrelor or prasugrel in most of my acute coronary syndrome patients. I prefer prasugrel certainly in my younger patients. It's also, much less expensive than the ticagrelor, so I tend to use that. Plus, it's once a day. Prefer the ticagrelor in medically managed non-STEMI patients. I use clopidogrel in my older adults, anticoagulated patients, or the high bleeding risk patients. And then I strongly consider 1 month of ticagrelor monotherapy in my high bleeding risk patients. There is shared decision-making for the dual antiplatelet therapy duration. I have a conversation with all my patients about that. And then I'm a huge believer that imaging-guided PCI is what's going to help me optimize my patients so that I feel more comfortable when I'm making that transition to the 1 month of ticagrelor, which certainly there's the data for that to support the dual antiplatelet. So this is a case I did actually last Friday before I came, and this is a patient that you can't see the whole angio, but the LAD is subtotally occluded in the mid portion, and the right is out, and you had a patient now with left main with a small channel and then circumflex disease, heavily calcified. So this is a patient that was started with an Impella and then a shockwave and then a stent placed. Now this is a patient that's 78 years old, and he has chronic kidney disease stage 3. He has a history of pulmonary fibrosis and atrial fibrillation is on apixaban. He was referred to the cardiac surgeons, and obviously because of the pulmonary fibrosis, he was not deemed to be a good surgical candidate, but he was certainly a high risk, a bleeding patient. And so we recommended, 1 to 4 weeks of oral the triple therapy, clopidogrel, aspirin, and he's on an oral anticoagulant. And after a month, he will switch over to just the oral anticoagulant and clopidogrel. And we did not use ticagrelor or prasugrel in this patient because of the triple therapy. And actually, I wrote the wrong age. He was 85, not 78. So that also sort of take that. So my key takeaways, remain on the strategy of 12 months of dual antiplatelet therapy. There were some good key points on that, if they could put that slide back. Clopidogrel still has an important role in selected patients. Individualize the dual antiplatelet therapy. I think 1 month of ticagrelor monotherapy. And then I think with those patients with anticoagulation, early transition, I think to clopidogrel therapy with that. And then personalized decision, and then imaging-guided PCI and radial access. So I'll stop here. Thank you very much.
Great. Thank you very much.